Pulmonary embolism. Pulmonary embolism occurs when a clump of material, most often a blood clot, gets wedged into an artery in your lungs. These blood clots most commonly come from the deep veins in your legs. If a blood clot is large or there are many clots, a pulmonary embolism can cause death. So to be more specific, a pulmonary embolism or a PE is the blockage of one or more pulmonary arteries by a thrombus, fat or air embolus, or tumor tissue. The word embolus derives from the Greek word meaning plug or stopper. Emboli are mobile clots that generally do not stop moving until they lodge at a narrow part of the circulatory system. A pulmonary embolus consists of material that gains access to the venous system and then the pulmonary circulation. The embolus travels with the blood flow through ever smaller blood vessels until it lodges and obstructs perfusion to the alveoli. The lower lobes of the lung are the most commonly affected. Approximately 10% of people with massive PEs die in the first hour. Treatment with anticoagulants can significantly reduce mortality. Here's a couple pictures of pulmonary emboli. The one on the left demonstrates decreased perfusion beyond the embolus location as the pulmonary embolus blocks the blood flow. The lung is ventilated, but gas exchange is decreased as there is no blood flow to the ventilated alveoli. The picture on the right depicts a large pulmonary embolus located within a pulmonary vessel. This picture shows a large embolus from a femoral vein lying in the main left and right pulmonary arteries. Most pulmonary emboli arise from deep vein thrombosis or DVTs in the deep veins of the legs. Risk factors for PE include immobility or reduced mobility, surgery within the last 3 months, especially of the pelvis or lower extremities, history of DVT, malignancy, obesity, oral contraceptives, hormone therapy, cigarette smoking, prolonged air travel, heart failure, pregnancy, and clotting disorders. Other sites of origin of PE include the femoral or iliac veins, the right side of the heart if you have arterial fibrillation, and the pelvic veins, especially after surgery or childbirth. Upper extremity DVT occasionally occurs in the presence of central venous catheters or arterial lines. These cases may resolve with removal of the catheter. A saddle embolus refers to a large thrombus lodged in an arterial bifurcation. Less common causes of PE include fat emboli from fractured long bones, air emboli from improper administration of IV therapy, bacterial vegetation or on heart valves, amniotic fluid, and tumors. The signs and symptoms of PE are varied and nonspecific, making diagnosis difficult. Clinical manifestations depend on the size and extent of the emboli. Small emboli may go undetected or produce vague, transient symptoms. Symptoms may begin slowly or suddenly. Dyspnea is the most common presenting symptom, occurring in 85% of patients with PE. A mild to moderate hypoxia may be observed. Other manifestations may include tachypnea, cough, chest pain, hemoptysis, crackles, wheezing, fever, accentuation of pulmonic heart sounds, tachycardia, and syncope. Massive emboli may produce a sudden change in mental status and hypotension. Complications of pulmonary emboli include pulmonary infarction and pulmonary hypertension. Pulmonary infarction, or death of the lung tissue, is most likely when the following factors are present. First, occlusion of a large or medium-sized blood vessel, which is defined as greater than 2 millimeters in diameter. Second, insufficient collateral blood flow from the bronchial circulation. Or third, a pre-existing lung disease. Infarction results in alveolar necrosis and hemorrhage. Occasionally, the necrotic tissue becomes infected and an abscess may develop. Concomitant pleural effusion is frequent. Pulmonary hypertension results from hypoxemia or from involvement of 50% of the area of the normal pulmonary bed. In a single event, an embolus rarely causes pulmonary hypertension. Recurrent pulmonary emboli gradually cause a reduction in the capillary bed and eventual pulmonary hypertension. Dilation and hypertrophy of the right ventricle can develop secondary to pulmonary hypertension. Depending on the degree of the pulmonary hypertension and its rate of development, outcomes can vary, some patients dying within months of the diagnosis and others living for decades. ABG analysis is important but not diagnostic. The PaO2 may be low because of inadequate oxygenation secondary to occluded pulmonary vasculature, preventing matching of perfusion to ventilation. The pH is often normal unless respiratory alkalosis develops as a result of prolonged hyperventilation or to compensate for lactic acidosis caused by shock. Abnormal findings are usually identified in the chest x-ray, such as atelectasis or pleural effusion, and the EKG may show ST segment or T wave changes, but they're not diagnostic for PE. Serum troponin levels and B-type natriuretic peptide or BNP levels are frequently elevated but not diagnostic. D-dimer is a lab test that measures the amount of cross-linked fibrin fragments. These fragments are the results of clot degradation and are rarely found in healthy individuals. The disadvantage of the D-dimer testing is that it's neither specific, many other conditions cause elevation, nor sensitive, as up to 50% of patients with small pulmonary emboli have normal results. Patients with suspected PE and an elevated D-dimer level but normal venous ultrasound may need a spiral CT or a lung scan. A spiral or a helical CT, also known as CT angiography or CTA, is the most frequently used test to diagnose PE. An IV injection of contrast media is required to view the pulmonary blood vessels. The scanner continuously rotates around the patient while obtaining views or slices of the pulmonary vasculature. This allows visualization of all anatomical regions of the lungs. Computer software reconstructs the data to provide a three-dimensional picture and assist in emboli visualization. If a patient cannot have contrast media, a ventilation perfusion or a VQ scan is done. The VQ scan has two components and is most accurate when both are performed. Perfusion scanning involves IV injection of a radioisotope. A scanning device images the pulmonary circulation. Ventilation scanning involves inhalation of a radioactive gas such as xenon. Scanning reflects the distribution of gas through the lung. The ventilation component requires the cooperation of the patient and may be impossible to perform in the critically ill patient, particularly if the patient's intubated. Pulmonary angiography is the most sensitive and specific test for PE. However, it's an expensive and invasive procedure that involves insertion of a catheter through the antecubital or the femoral vein, advancement of the catheter to the pulmonary artery, and injection of the contrast media. The accessibility and accuracy of the spinal CT has greatly diminished the need for pulmonary angiography. Prevention of PE begins with prevention of DVT. DVT prophylaxis includes the use of sequential compression devices, early ambulation, and prophylactic use of anticoagulation medications. To reduce mortality risk, treatment is begun as soon as PE is suspected. The objectives are 1. To prevent further growth or extension of the thrombi in the lower extremities, 2. To prevent embolization of the upper or lower extremities to the pulmonary vascular system, and 3. To provide cardiopulmonary support if indicated. Supportive therapy for the patient's cardiopulmonary status varies according to the severity of the PE. Oxygen can be given via mask or cannula, and the concentration of the FiO2 is determined by ABG analysis. In some situations, endotracheal intubation and mechanical ventilation are necessary to maintain adequate oxygenation. Respiratory measures such as turning, coughing, deep breathing, and incentive spirometry are important to help prevent or treat atelectasis. If manifestations of shock are present, IV fluids are administered, followed by a vasopressive agent as needed to support perfusion. If heart failure is present, diuretics are used. Pain resulting from pleural irritation or reduced coronary blood flow is treated with opioids. Immediate anticoagulation is required for patients with PE. They serve two key roles. First, they keep the clot from getting any bigger. Second, they keep new clots from forming. They do not dissolve blood clots. The body normally does that on its own over time. Subcutaneous administration of low molecular weight heparin or LMWH, examples are enoxaparin or Lovenox or fondaparinux, have been found to be safer and more effective than unfractionated heparin. It is the recommended treatment of choice for patients with acute PE administered once daily. Advantages of low molecular weight heparin over unfractionated heparin include greater bioavailability. It can be administered subcutaneously. It has a longer duration of therapeutic effect, and monitoring of the APTT is not necessary or useful. Unfractionated IV heparin can be as effective, but is more difficult to titrate to therapeutic levels. Warfarin or Coumadin, an oral anticoagulant, should be initiated at the time of diagnosis. Warfarin should be administered for at least 3 months and then reevaluated. Alternatives to warfarin include apixaban or Eliquis, dibigatran or Perdaxa, and indoxaban or Savasa. Anticoagulant therapy may be contraindicated if the patient has complicating factors such as blood dyscrasias, hepatic dysfunction causing alterations in the clotting, overt bleeding, a history of hemorrhagic stroke, or heparin-induced thrombocytopenia, HIT. Although not common, some healthcare providers use direct thrombin inhibitors in the treatment of PE. Similarly, fibrolytic agents such as tissue plasminogen activator or TPA or activase may help dissolve the pulmonary embolus and the source of the thrombus in the pelvis or the deep leg veins, thereby decreasing the likelihood of a recurrent emboli. Hemodynamically unstable patients with massive PE in whom thrombolytic therapy is contraindicated may be candidates for an immediate pulmonary embolectomy. Embolectomy, which is removal of the emboli to help decrease right ventricular overload, can be achieved via a vascular catheter or surgical approach. Surgical outcomes have improved in recent years, in part due to rapid diagnosis and enhanced surgical procedures, with mortality rates decreasing from 30% to 19%. To prevent further emboli, an inferior vena cava or an IVC filter may be the treatment of choice for patients who remain at high risk and for patients who anticoagulation is contraindicated. This device, inserted percutaneously via the femoral vein, is placed at the level of the diaphragm in the inferior vena cava. Once inserted, the stent expands and prevents migration of large clots into the pulmonary system. Complications associated with this device are rare, but include misplacement, migration, and perforation. These pictures depict some of the different types of inferior vena cava filters and an image of a filter in place. A is a Greenfield filter, B is a bird's nest filter, and D is a Venatech LP filter. Nursing measures aimed at prevention of PE are similar to those for prophylaxis for DVT. The prognosis of a patient with PE is good if therapy is promptly instituted. Keep the patient on bed rest in a semi-Fowler's position to facilitate breathing. Administer oxygen therapy as ordered. Assess the patient's cardiopulmonary status with careful monitoring of vital signs, cardiac rhythm, pulse oximetry, ABGs, and lung sounds. Maintain an IV for medications and fluid therapy. Monitor laboratory results to ensure therapeutic ranges for INR for warfarin and APTT for IV heparin. Monitor the patient for complications of anticoagulant and fibrinolytic therapy such as bleeding, hematomas, and bruising. Provide appropriate interventions related to immobility and fall precautions once the patient is permitted out of bed. The patient is usually anxious because of pain, inability to breathe, and fear of death. Carefully explain the situation, the medications, and provide emotional support and reassurance to help relieve the patient's anxiety. Patient teaching regarding long-term anticoagulation therapy is critical. Anticoagulation therapy continues for at least 3 months. Patients with recurrent emboli may be treated indefinitely with anticoagulants. INR levels are drawn at intervals and warfarin dosage is adjusted. Some patients are monitored by nurses in an anticoagulation clinic. Discharge planning is aimed at preventing worsening of the condition and to avoid complications and recurrence. Teach the patients measures to prevent DVT. Reinforce the need of the patient to return to the healthcare provider for regular follow-up examinations. Expected outcomes are that the patient who has a PE will have adequate tissue perfusion and respiratory function, adequate cardiac output, increased level of comfort, and prevention of further recurrence of pulmonary emboli.